Thank you so much, and thank you for welcoming me here. I feel extremely fortunate to work with mental health colleagues. I've learnt lots from many people in the room over the years, a new forum for me. So very grateful. As Joanna says, I'm clinical lead for tobacco, lung cancer and health inequalities across Cancer Alliance and ICB, and I hope I can raise myself to Mary's challenge of being clinical lead for agitation and being a critical friend and challenge. And poor Rachel has put up with me over the years every time I'm saying, but can we not do this? Can we do it this way? And slightly head in hands and the next day coming out with a project proposal. So I hope I'm living up to that for you all. We've obviously been really fortunate to work on some incredible work streams as part of the Tobacco Taskforce, not least the Tobacco Long-Term Plan implementation in our acute trusts and the mental health trusts, as you're all here today, but also running the regional staff tobacco dependency offer, which was one of very few national pilots, and we led the way on that and had phenomenal outcomes, especially from our mental health staff colleagues. So great work there. And our work in the pregnancy work streams in maternity, again, really powerful, a key player nationally. So lots of kind of different work streams in NHS settings, and lots to learn from those about the different areas that we cover and that we see in our acute trusts. So by way of example, if I was just picking one of those, and when we were up at Northumbria discussing with colleagues the other day, one of their medical directors reflected on this and really kind of made me think, if we think about our maternity pathways, we've completely changed how we deliver tobacco dependency in maternity, and we're seeing phenomenal results. And he kind of commented on that. Look at how smoking at time of delivery has just dropped. And what does that mean for the people in our communities, taking babies home to smoke-free homes, giving them the absolute best start in life? We're changing a kind of a life narrative for that group. Why do we get such good quit rates there? What are we doing differently? And as you probably know, it's a very different delivery model compared to our acute trusts, where we might see people for a day or two while they're in hospital and then they're off into the ether. We're embedding that support along the whole of their pregnancy pathway. It's built in with their clinical care. That's exactly what we're doing in mental health settings, and it's what we could be doing with our long-term conditions in acute settings as well. We get great outcomes there. And I think, so we've got all these really inspiring work streams and we're getting great results, learning lots from all of them, but we've still got those left behind. And I think I was tempted to sort of use the phrase that the people cross all of these segments. You know, they might have some of their time in maternity care, they might have some of their time in an acute trust with an acute illness, they might have a significant burden of mental health problems. But what I think the real problem is people who fall between all of those gaps and services. So we know 30% of smokers have a mental health condition. We know the higher prevalence of smoking in people with serious mental illness. All the presentations so far have already touched on the profound impact that has on their physical health, how long they live well for, their economic activity. And smoking is the biggest contributor to that. We know the injustice of people with schizophrenia who have double the rates of cancer. I see it in my lung cancer clinics every week. Heart disease, respiratory disease, compared to age-matched controls, it's just not fair. And the patients don't fit into one group. There's huge overlap between serious mental illness, tobacco, addiction, dependency on other substances, and like I say, long-term health conditions. So there should be a group who benefit from being helped by all of these services that they touch. But unfortunately, too often, I think they slip between all of us. And that's the danger, that what should be ours and being touched by all our services actually ends up being none of ours. So in one particular clinic I do a week, and I'm just one professional in one acute trust, and I've only got some extra resource in one of the clinics I do. So I see all suspected lung cancer referrals coming in through this clinic, and every week there's a handful of people who would fill these criteria of complex lives, multiple and complex needs, high prevalence of mental health, addiction, substance dependency. And this wonderful lady came acutely to our A&E department one night, having coughed up blood, and was terrified. And I think, people see A&E departments as the place where the lights are always on, so you can go and you can get seen. And we know they're disproportionately used by people who might not otherwise use health services appropriately. But it was busy, and we keep putting out a mantra that you're going to wait for hours, and unless you're at death's door, there's no point being here. You should go and see your GP. You know, all these kind of comments coming out into the waiting room. We don't give people food or drink. We definitely don't help with NRT when you're still in the waiting room. And ultimately, she left the department without getting treatment for the problem. But we've got a kind of safety mechanism where anyone who gets as far as an abnormal chest X-ray gets alerted to the lung team. So it came on my radar as a referral into a possible cancer pathway. To investigate that, we needed her to have some blood tests and go for a scan, and we just expect everybody to do the same thing. Just get a telephone call or a text message about those appointments, turn up and have them. And some people just tappy-lappy on down that pathway, and other people absolutely slip through on it. So she didn't turn up for an appointment for a blood test, and therefore we couldn't book her for a CT scan. And we've got policies, as I'm sure many acute trusts do, that you miss 2 appointments and you're out. So that's our provision. It's embarrassing. This lady had pregnancies where she was a smoker as well, but actually because of she'd had very adverse childhood experiences and then become a victim of domestic violence herself. And so her experience of her pregnancy care was one of social services are involved. They're coming to her house. The emphasis on keeping children and the unborn children safe. It were, not a supportive therapeutic relationship. So she actually was driven into using other drugs and drinking during pregnancies rather than the supportive nurturing relationship you would get if you were able to come and meet your community midwife at the preset appointment every couple of weeks. So getting a negative experience and reinforcing her mistrust of health providers and the agencies that should have been looking after her. She doesn't want to come into, that was her chance when she came to A&E to get admitted as an acute inpatient, and we could have helped with her tobacco, but she disappeared in the night. She falls outside of mental health services because she's turned them down. She thought that she would be judged badly if the problems with her mental health, if she was reaching out for support. And she's obviously not going to be helped by occupational health work stream. She left school early because of the adverse childhood experiences. She can't read. She's never had a job. She should be supported by everything we're doing, and she's actually supported by none of them. We've got a good outcome in the end, and tobacco has been the enabler. We've had to make very particular, reasonable adjustments to build a trusting relationship. But if we text her and we take products out to her, she is embarking on a quit journey, and it will be the thing that enables her to engage with the rest of her care. I don't want to teach a granny how to suck eggs, but there's a complicated relationship, isn't there, with smoking and mental health, and it's often seen as sort of self-medicating or a way of dealing with things, and the misattribution hypothesis that Mary touched on, that you've got high levels of addiction. You started from a young age in a developing brain and a high requirement for nicotine, and that very good feeling when you have a cigarette combined with the horrendous withdrawal feeling when you can't have one, making you think that smoking is actually good for your mental health, not just the people who are vulnerable and dependent on tobacco, but for the healthcare professionals around them who've had to live with the consequences of people withdrawing from tobacco. And, again, in an acute setting, we see people all the time withdrawing from alcohol or withdrawing from drugs, withdrawing from tobacco. All of them are just the same. But for 2 of them, we say, no, you can't do that. You can't drink on site. You can't go out and inject drugs. Oh, but it's your right to smoke. So, we let them go and do that, and huge cultural problems with that misattribution. And potentially even a causal relationship, isn't there? So, when you do the sort of, I've forgotten the word, it begins with M. The research that's looked into whether smoking might actually cause mental health, that people who smoke are more likely to develop some serious mental illnesses. So if you are a smoker, your risk of developing schizophrenia is increased by somewhere between 53 and 127%, and serious depression 54 to 132%. So it's a complicated interplay between life experience, poverty, genes, comorbidity, and tobacco dependence. But we know that all these things are intimately related. There's some evidence of increased risk with bipolar, and we haven't quite worked out the relationship with things like ADHD or anorexia, but they're just unfathomably interlinked. And we know that being a smoker obviously affects your experience of your mental health illness and the outcomes that you get from that. So with bipolar, knowing that people treated for bipolar smokers are more likely to have an earlier onset of the disorder, worse symptoms, higher risk of suicide attempts, and also have comorbid anxiety or other substance misuse. and are linked with increased suicidal ideation. People with ADHD are more likely to smoke in pregnancy, and maternal smoking is an independent risk factor for ADHD. So there are lots of links and interplay that's complicated and make it hard to untangle all these, but also proof that if tobacco is the thing that we can make a lever on, we can make a profound impact. So that we know that people who smoke have a more severe symptoms of psychosis and spend longer in hospital. And I guess that comes back to Mary's point about recognising the tobacco dependency as a clinical condition that we can treat. And it not only has an impact treating that condition, but it also has an impact on the treatment for their mental health. We know it affects drug levels, and you get away with lower doses of medications if we can help people to become tobacco-free. And we know in terms of escaping this cycle that the poverty that comes when you're dependent on tobacco and other substances, it's very empowering to be able to release people from being trapped there. And it's this cycle, isn't it, of smoking increasing the risk of poor mental health, the poor mental health increasing how much we're smoking and how dependent people are. That higher level of dependency decreases the likelihood of being able to quit, and then it has a profound impact on physical health, economic activity, relationships, and it becomes a cycle, a reinforcing cycle. And we know prevalence of serious mental illness is going up, but it's going up disproportionately across our different IMD deciles, and that it, again, intimately linked with poverty, serious mental illness, tobacco. So as Rachel and Joanna have touched on, we were really lucky when the opportunity came to do more work as an early implementer site for an enhanced targeted offer for tobacco support for serious mental illness. And we were very keen to be involved. And I'm not going to touch on the offer because I know the actual people who've done the do and done the really inspiring work are in the room. But just thinking about how it made us think differently about what our offers of support look like. So the NHS national team had suggested a primary care model as one of the three potential models, and suggested what that might look like, how people with serious mental illness brought in for physical health checks might have an opt-out referral, and what that pathways look like. And that was the primary care offer was one that really caught our attention, because when you do the mapping of the data, and we've got phenomenal resource with NEXT to be able to look at exactly where our smokers are and what's happening with them. We looked at the top 10 PCNs with the highest prevalence of SMI, and they accounted for a quarter of those with SMI who smoke just in those 10 PCNs. So we envisaged that you could do some really targeted work to get to a huge population of people with serious mental illness who are dependent on tobacco. And actually, when you think about the numbers who actually make it as far as secondary care, mental health care needs, that's a very small proportion compared to those who are being managed out in the community. And even smaller again when you think of all the people like the lady I described who just aren't diagnosed or aren't within services. So I guess I'm challenging us all to think, where are our smokers who have serious mental illness? Where are the group, and how do we reach them? And this is a summary of the huge amount of work that's gone along across the region to be able to deliver this national data set reporting back to national. That over the 2 years that the acute inpatients in both our acute trusts and mental health trusts have been recording smokers, we've found 60,000 smokers. Sanjay was saying 250,000 in the last year, wasn't he? A huge proportion of those are in the northeast. And I suspect, as we all see in our day-to-day basis, day-to-day professions, that the people who are facing additional challenges, multiple and complex needs, mental illness, are the people who are dropping off at each of these levels. They're either not identified because they've self-discharged, or they're off the ward, or they're out, or they're not engaging with the support because of the way in which it's given, or they're not in the frame of mind to be able to accept it when it's first offered to them, or they're lost to follow up when they're discharged to community services. So it's not hard to find these people. They're within this data set that we've already got. Sorry, I'll rush through. I think they are in our acute waiting rooms, just like that lady was. It's where our lights are always on. Our poorest communities are often wrapped around our hospitals, and they use us because they know that there's health professionals there. We would find a high prevalence of people with mental illness and tobacco dependency if we look within our acute inpatient cohort in our acute trusts. And these people often have multiple contacts with different services, whether it's ourselves in secondary care, primary care, mental health, drug and alcohol services, social services, not all of them are always adding value. There's risks of us each making our own silo assessment, but saying that, oh, it sits with somebody else. They haven't got a named mental health problem, or drug dependency is the biggest problem, or they think that the mental health needs sorting out. And these people are really vulnerable to fall in between the nets. And I had another example there, but in the interest of time, I'll scoot over. So I think the statement that really rings true with me is health inequalities are unfair and avoidable. We can change this. And as Mary said, we should be impassioned to be able to make changes. And if we want to do better, we really have to challenge how we make our services fit the needs of the population around us. The handful of people I see every week all accept help, but the help that I'm then able to offer them does not meet their needs. So telling them they have to go somewhere at a certain time or wait for a letter to come is not the same as being able to put products in somebody's hands and say, I've got an advisor in the next room, do you want to just chat to them about what is available? We have to challenge ourselves on that. I don't think there's any better example of that than the enhanced SMI offer that teams in this room are delivering. They're building sustained therapeutic, enduring relationships and trust, and using tobacco as a kind of key tool for being able to improve people's lives. And the models that you'll share really enforce that. It's thinking about what matters to me, personal support plans, that enduring relationship. And we can all adopt some of that in our acute trusts. We can think about how we embody that in the work we do at Region. And I think we can all challenge ourselves to think about the graphic that we shared before. If we make it better for our most vulnerable people in our communities, we make it better for everybody. So we've got a real duty to think about the experience of the people who need these services the most and make the services fit for purpose for them. Thank you. Stop for breath.